Nearly 50% of U.S. adults have high blood pressure, but fewer than half of adults have it controlled.
Hypertension is one of the most prevalent conditions that we see in this population, and so that's where we really saw the need in the community.
Barriers to hypertension management for our patient population can vary from cost of medications, education to understand why it's important, especially if they don't have symptoms of high blood pressure.
Target BP helps healthcare organizations improve blood pressure control by providing professional education resources, quality improvement tools, and annual achievement awards.
We've used the Target BP resources in several different ways, not only for the patients, but also for our team here. We've used them to help educate not only the providers, but also the medical assistants when checking patients' blood pressure.
So tools that have been very, very helpful for all of our staff is patient positioning poster for taking a blood pressure at home. So we now have those in all of the rooms, and it serves as a great reminder for staff to make sure that patients are positioned properly.
We had one medical assistant. She'd been working as a medical assistant for about 20 years. She's like, nobody ever told me this. No, I've been taking blood pressures wrong for 20 years.
Another pamphlet is in multiple languages, so of course English, Chinese, and also Spanish. And it shows the best tips, healthy eating, lifestyle, how to best measure your BP.
And then we typically print off the resources for patients as well so that they know how to adequately check blood pressure at home.
When patients start sending results into the clinic, the nurse will take that information, have communication with the provider. It's just stimulating more communication on a frequent basis.
But Target BP is really about like the whole health center. It starts even at the front desk, to the call center, to our dietitians, our pharmacists, our medical assistants, our nurses. Really everyone involved in the patient's care plays a role when it comes to Target BP.
Patients are thrilled real time in a week or two that they can see that their lifestyle changes or their med changes are making a difference.
In the past year, we've seen an increase in well-controlled blood pressure from 72% to 80% of our population.
We were about 52, 53% hypertension control and improved that to 80%. It's been great for everybody.
Join the growing Target BP community to improve blood pressure control for patients nationwide.
Welcome everyone to the Target BP webinar, Partnering with Patients, Step 3 in Hypertension Control. I'm Allison Smith. I'm a nurse and a public health professional, and I serve as the Initiative Director for Target BP on behalf of the American Heart Association and the American Medical Association. Thank you for joining us. We are delighted to have so many people here with us today. This presentation is being recorded and will be available on demand and with enduring CME and CE credit in the future. I also want to thank the team members who contributed to the video that you just saw. Those who are on the screen, as well as those behind the scenes from Heart of Ohio Family Health in Columbus, from Primary Care Associates in Appleton, Wisconsin, and from Chinatown Service Center in Los Angeles. We appreciated them sharing how Target BP has had educational programs, practice resources, and awards that have contributed to their quality improvement and outcomes. They represent 3 of nearly 2,000 organizations across the country who have prioritized blood pressure control. So we're grateful for their efforts and to everyone for joining us today in your pursuit of better blood pressure control for the patients that you serve. With that, I want to do a brief housekeeping. On the next slide, I'll emphasize that we've enabled the closed captioning functions, and those you can adjust to your own preferences. On the next slide, I also want to emphasize that we've enabled the Q&A and the chat functions. In the chat, we welcome you to introduce yourself, where you're from, and get the conversation started. We also encourage you to use the Q&A functions for any questions that you have for us or for our presenters. You'll be able to upvote those questions so that your favorites will filter to the top of the list, and we'll get to as many as those as we can during the Q&A section toward the end of our event. On the next slide, it's my honor to let you know that we'll have CME and CE credit available, and here are the accreditation statements for that. The link will be available at the end of the presentation as well as in a follow-up email. On the next slide, I want to remind you that Target BP is really grounded in the AMA MAP framework, which helps us organize our approach to quality improvement in hypertension control, starting with measure accurately to make sure that every patient's blood pressure is measured accurately every time, to address the concerns of diagnostic uncertainty that interfere with diagnosis and treatment. We also focus on acting rapidly in the MAP framework to initiate and intensify treatment when indicated to address therapeutic inertia. And today our focus is on partnering with patients. The important things that we do to promote self-management through self-measured blood pressure monitoring and medication adherence, but lifestyle change in particular is today's focus, and addressing those risk factors that can improve blood pressure control or prevent it from occurring altogether. On the next slide, we'll move to introduce our faculty for today. I'm delighted to have Ruth Alma Turkson-Arkan and Stephen Jurassic to join us today. Dr. Jurassic is a clinical investigator and a fellowship-trained practicing internist with a primary area of interest in blood pressure. He's currently involved in several clinical trials examining healthy eating patterns, cardiovascular risk factors, and blood pressure. He's also interested in disparities with regard to food access and participation in clinical trials. Dr. Ruth Alma Turkson-Arkan is a family nurse practitioner and a clinical investigator with research interests in health disparities, social determinants of health, and cardiometabolic health. Her current research focuses on hypertension, its associated comorbidities, complications, and prevention, as well as projects examining racial differences in office, ambulatory, and home blood pressure patterns. I'm really delighted for us to be walking the talk today of team-based care with these nurse and physician faculty members. And with that, it's my pleasure to turn it over to Ruth Alma Turkson-Arkan to start our presentation today. Thank you.
Thank you so much, Allison, for the kind introduction. Next slide, please. Oh. All right. Thank you so much for the kind introduction. So this is what we'll be talking about today, partnering with patients to improve blood pressure. And today, like was said, we will be focusing on lifestyle modifications. So next slide. Here is, we have no financial relationships. However, we are both on 2 trials that focus on DASH pattern groceries to reduce blood pressure in Black adults who have treated and untreated blood pressure. And this is funded by both the AHA and the NIMHD. Next slide. So here we're looking at some statistics that are on hypertension in the US. And I'm sure we are quite familiar with all these statistics. However, I'll go over them very, very quickly. So about 1 in 2 adults in the US, which is about 200 million adults, have high blood pressure. And this doesn't include the fact that over 14 million people have undiagnosed hypertension. And hypertension or high blood pressure can be quite expensive to treat. Looking at here in the middle, we can see that annual costs in the US related to hypertension managed in about between 2003 and 2014 was about $131 billion. In addition, we have about 75% of persons who have hypertension not having their hypertension controlled, and another 34 million who have hypertension being untreated because either because they are not taking their medications as prescribed or they haven't been prescribed enough medication to manage their blood pressure. Add to this, people are undertreated, 34 million undertreated, and another 24 million undermanaged and therefore are not at their target blood pressure. Next slide. So when we talk about lifestyle modifications that help improve blood pressures, we're usually talking about non-pharmacologic interventions that can prevent and help control blood pressure, and which we have to incorporate into our daily lives. Essentially, we want to make these habits. And so these habits or behaviors are recommended regardless of a person's hypertension status, right? It's number one, it's never too late to start incorporating these behaviors into one's daily life. And something that I guess I would talk about more and more is looking at accountability. So accountability is very, very important. And this includes accountability to oneself or accountability to a partner or to your healthcare team. And it just helps with maintaining this behavior. So when we talk about lifestyle changes or modifications that are recommended for low end blood pressure, there are several, but I would like to highlight those that, so sorry, next slide. Um, right. Very briefly, I'd like to highlight some lifestyle changes and modification that are recommended for lowering blood pressure. And there are several and that are on this slide. And as we go through this presentation, we'll go into more and more detail over them over the next few slides. But one thing that I want you to take note, especially in this slide with asterisks on them, is that these are the interventions or approaches that have the strongest evidence for reducing blood pressure. And very briefly, this includes things like maintaining a healthy weight, adopting a healthy diet, reducing your sodium intake, increasing your potassium intake, increasing physical activity, reducing alcohol intake, and so on. And so when we first look at maintaining a healthy weight, whether you're looking at BMI, which for what we're looking at, ideal is less than 25, or you're even looking at waist circumference, which is different for men and for women. For men, you're looking at less than 40 less than 40 inches, and for women, it's less than 35 inches. And so waist circumference is a proxy for central adiposity. And then you look also at a heart healthy eating. So the DASH eating pattern is one of the healthy eating patterns that are rich in fruits and vegetables, also high in whole grains, lean protein, low fat, for example. And low also in sugar sweetened beverages, and that has been shown to lower blood pressure and improve health overall. And so when we're also looking, when you're looking at diets, you also want a sodium intake that is restricted or is less than 23 milligrams per day. Essentially, the lower the better. So and then the next thing is increasing your potassium intake. And this may be in the form of supplementation or through diet or through the diet. And we'll talk about this more into detail in the next few slides. It may not be for everyone, especially in the persons who may be taking some kind of medications for blood pressure or who may have chronic kidney disease, for example. With physical activity, you're looking at having 150 minutes or more of physical activity, whether it's structured, aerobic, resistance, and with alcohol, again, different for men and women, less than one drink for a woman, and less than 2 drinks a day for a man. And we'll talk about some of this later. So next slide, please. So now looking at healthy weight or maintaining a healthy weight, and it involves a number of things. So the first thing that we are looking at is staying active. And so with physical activity, for the first one, and then the second one is for eating healthy and then monitoring your weight status. We'll talk about that a little bit more later. But with staying active and with physical activity, this can be done either to lose weight or then to maintain your weight, maintain the muscle mass, or prevent fat gain once someone reaches their ideal weight or waist circumference, for example. And when we talk about eating healthy, we've talked about the DASH eating pattern, but we also want to talk about practicing mindful eating. So for example, example, not eating in front of a screen, a television, adhering to recommended portion sizes, and avoiding overeating, for example. It also involves having some sort of regular meal schedule and meal plan. So think about meal planning. So planning meals ahead of time. And as always, it's important to stay hydrated with water and avoid sugar, sweetened beverages. Next slide. And so now we're talking about some things to consider when striving to maintain a healthy weight. And so when we're looking at the clinician's perspective, as clinicians, we want to frame our discussions with patients around their overall well-being, their energy levels, versus solely focusing on their weight. And for some people, for certain cultures, this can be stigmatizing, right? So in those discussions, you want to adopt a non-judgmental approach, right? You want to avoid to them using words like obese or overweight directly, especially in the beginning. And then you want to also recognize that different people have different ideals for their body habitus, and also try to avoid promoting a single westernized ideal body habitus. Some people may want or may need referrals to maybe nutrition specialists who can help them think through foods or recipes that may be culturally meaningful to them, maybe culturally relevant to them, for example. When we're talking about social gatherings, food tends to play a huge role in social gatherings as well as celebrations. And we know that when people are gathered together, they tend to eat more. And so we want to also talk through strategies that address these kinds of things. For example, portion control, but still in a communal setting, creating balanced meals, especially when you have people with food restrictions, for example. And in addition to referrals to the dietitian, you want to also consider other recommendations, involve maybe their support group, involve maybe their family, look at community-based weight management programs, for example. And I think I mentioned support groups also. So in these support groups, they can also share the experiences and strategies with their peers, so that and also involve some sort of social activities that involve movement. Next slide, please. Again, when it comes, some of these, especially, when you're talking about weight and you're talking about healthy eating, sometimes they can overlap. So again, we're talking about maintaining a healthy diet. The DASH eating pattern is one that we've talked about that is recommended. The literature shows that it does, and Stephen will talk a little bit more about that it um, uh, has been shown to decrease blood pressure. So you want to focus on eating whole versus processed foods, eating lean proteins, stuff that have healthy fats are high in protein. And I also want to point out this caution here that, again, increase your potassium intake may not be appropriate for everyone, especially those who have chronic kidney disease or who may take potassium-sparing medications. And we know that some of the blood pressure medications may be in this category. Next slide. And just very briefly, some things to consider here. Again, experts in nutrition can help. In general, you may want to have a low threshold for referring to experts in general, and dietitians can help people identify what would work for them, what are healthy alternatives to some things that they are already used to. For example, for people who may not have adequate skills, maybe cooking demonstrations may be able to help. They're often offered in the community here in Boston, Massachusetts. We have cooking demonstrations in libraries. Libraries have, cooking kitchens, for example. You can also look at community or urban gardens, for example, farmers markets. Those are places that people can get to obtain locally sourced healthy produce, for example. And then I'll pass the baton on to Stephen here.
Great. Thank you. Next slide. So, where is some of the evidence for healthy eating coming from? When we talk about DASH, I think a lot of us on this call may have heard about DASH, right? Dietary approaches to stop hypertension. And so this is from a trial that was published in 1997, where they compared three different dietary patterns. One was a control diet, which was the reference group typical of US diet at the time. Another arm that people were randomly assigned to was a fruits and vegetables diet that was like the control or reference diet, but was enriched for fruits and vegetables. And then the third assignment was the combination diet, or as we refer to it now, the DASH diet, which was also richer in calcium and magnesium, emphasized the low-fat, fat-free dairy, but then ultimately has been described as being a diet rich in fruits and vegetables, low-fat dairy, with reduced saturated and total fat. And you can see here on the right the main results from the study. So this is systolic blood pressure, and then the blood pressure tracked over the 8 weeks of the trial. And what you can see is that the control diet is up at the top, and the middle is the fruits and vegetables diet, and at the bottom we see the combination or DASH diet, showing that very early on there was reduction in blood pressure, and this was maintained over the duration of the study. There were similar results observed for both diastolic blood pressure and LDL cholesterol as well, suggesting that this diet is effective for a number of cardiovascular risk factors. The study itself enrolled about 459 adults from 4 different locations throughout the United States. This study was about half women and 60% Black adults. It included individuals with elevated blood pressure and hypertension who did not have cardiovascular disease or were not using hypertension medication use. So as a prevention cohort, a relatively diverse cohort with implications for folks throughout the U.S. Next slide. Okay, and so another evidence, so transitioning from a healthy dietary pattern to another important recommendation, which is to reduce sodium intake. And one thing that's important to recognize is that the first early trial on DASH, that 1997 trial, did not emphasize sodium reduction. And in fact, all 3 of those different dietary assignments, so the control, fruits and vegetables, or DASH, all had about the same sodium content. And so, however, beyond dietary pattern, there is value in reducing sodium intake. And the American Heart Association recommends consuming less than 2,300 milligrams per day of sodium for someone who consumes 2,100 kilocalories, and that could vary based on your calorie requirement. But ultimately, it would be better to consume even less than 1,500 milligrams per day. There are ways to achieve this practically in the US. One is to limit restaurant meals. So restaurant foods, both fast foods, entrees, sides, typically have higher sodium content than what might be found or prepared at home. Salt can be used to enhance flavor. You could try to ask for no salted food. Sometimes this option exists in restaurants, though many people, when they're going out to eat, aren't necessarily thinking about a healthy meal. They might be thinking about other things, but it's important that this can be a strategy people could try. Try to encourage people to prepare meals at home. And this includes using herbs and spices without salt as replacement of salt. Many people say, well, you know, lemon is a great flavoring. It stimulates similar taste receptors in the tongue as salt and sodium. So it can be a nice substitute if that's what people are trying to achieve. I'll point out that it does take some time for people to adjust to a lower sodium diet, but it can their taste can adapt over time, and after a while, people get more comfortable with lower sodium. Rinsing canned foods. Sometimes, you know, we just encountered this. Was visiting a community church in Selma, Alabama last week with the American Heart Association, and someone was telling us how they were trying to be very careful with eating fruits and vegetables, and it turned out that their blood pressure got worsened when they adopted a higher vegetable diet, and they were eating a lot of high sodium canned vegetables. And so it's important to bring that to people's attention. Try to limit processed foods. Use salt substitutes when you can. You know, some people tell me, listen, I can't prepare eggs for breakfast without adding a dash of salt. Well, we try to discourage people from doing too much. Sometimes people say, well, adding it on the surface is better than getting a high sodium product, so it's still kind of a net reduction. One strategy I say to my patients is, listen, if you're going to do it, and if your family really wants that, try to make the salt healthier by using a salt substitute. And there's a number of brands freely available on Amazon and other places where you can have a higher potassium intake to improve or reduce the sodium. And then check food labels. There's a lot of hidden sodium sources in the US. People say, well, I don't eat a lot of salty things. I don't eat the chips, I don't eat the pretzels, but soup is a big common source. Bread and rolls is in the top 10 often. We can't really taste that, but yet a lot of folks are eating bread and rolls. There's sauces and condiments. We think about, people say, I had a salad. Well, what did you put on that salad? Oh, I just put on salad dressing. Well, did you do just the 2 tablespoons that was recommended, or the one, or was it a low sodium? And you find out, oh, well, actually it was, a quarter of my daily value was in a serving of salad dressing, and I probably exceeded it when I put it on my salad. And so that's the kind of conversations we want to consider. Tomato sauce. A lot of people like to do spaghetti with a marinara sauce. Well, some of those tomato sauces are very high in sodium, and so that could be a simple substitute as well to improve things. Next slide. And then other things to consider, so again, identify these common high sodium sources, right? So ingredient seasonings that are just persistently high in sodium, try to avoid these, right? Bouillon cubes, salt fish, seasoning cubes, soy sauce, and try to look for, just an alternative that would replace that. Avoid the processed and packaged foods commonly consumed, like canned corned beef. So again, there are some products that are just, they're going to be high in sodium, and it's really not about substituting. It's about kind of just changing maybe selection of food. Emphasize flavor enhancement of herbs and spices instead of relying heavily on salt. We talked about that. Provide practical tips for reading food labels related to sodium content, so improving nutrition literacy. Encourage cooking at home. And then working with local restaurants, this is kind of at the community level, to offer lower sodium options instead of popular dishes. Sometimes even the restaurant chefs might be open to learning new things and enhancing their offerings. Next slide. Okay, another important evidence item is increasing dietary potassium intake. Okay, and so this is kind of another item that is recommended as with greater strength of evidence. And what's tricky about this, so I think many people love the idea of eating more potassium in your diet because maybe we like, especially among those in the nutrition field, all of us sort of gravitate towards the fruits and the vegetables. We like the kind of colorful vegetables, and so we might say, oh, this is a natural thing too. This is more fun, right? Restricting sodium is less fun. Promoting healthy, tasty fruit is more fun. But I think it's just important to recognize that there are some fruits, some vegetables that are naturally higher in potassium than others. And so we highlight a number of them here, and it's not necessarily universal, right? So when we think of higher potassium foods, we're thinking bananas, oranges, cantaloupe, kiwis, dates, prunes, sweet potatoes, spinach, kale, beets, carrots, potatoes, tomatoes, some beans, lentils, soybeans, avocados, and then various different forms of some beverages. And we talk about the salt alternatives. We talked about that already, and sort of the concerns potentially with those who naturally higher serum potassium, like those with CKD. But I just want to point out that, some of the literature can be mixed on the health benefits of dietary potassium because of what the media is for containing that potassium, right? And so if you're getting your potassium through, let's say, a fruit juice, orange juice is naturally higher in potassium. Well, that might be great for the potassium, but then you should also be thinking about the sugar, the added sugar side of things. And so it can be a little nuanced, but it is an important thing to emphasize. Next slide. And when you look at the relationship between sodium or potassium with blood pressure, so on the left side is a trial from Filippini and colleagues, published in Circulation, based on 85 trials. So this is a meta-analysis, and what you can see is a linear relationship. So the higher the sodium intake, the higher the systolic blood pressure, and it doesn't really matter where you're starting or where you go to along the continuum. It's pretty linear. Potassium, in this other meta-analysis based on 32 trials, is a little more nuanced. And you can see in certain cases, increasing from the 0 to the 30 to 60 range, you see a bigger reduction, negative difference in systolic blood pressure, but then something more neutral as you get to higher values. And so based on this, many people say, well, potassium should be more emphasized in settings where there's limited intake at baseline, and not shown here, but it also can depend on how much sodium is being consumed in the background. So if you consume more sodium, potassium has a greater effect at helping the body rid itself of sodium and lowering blood pressure as well. So less linear relationship, but still quite important. Next slide. And so why lifestyle, why we emphasize all these things so much? And I just want to highlight two big trials that show not only the blood pressure benefit, but also the cardiovascular disease benefit. So this is a really important study that emphasizes the importance of sodium and potassium. Here is it's the SAS trial conducted in China, 600 villages, over 20,000 people, a cluster randomized design. They used a salt substitute with 25% potassium. And what they found is reduction in stroke, major cardiovascular disease events, and all-cause mortality, with no increased risk that they could detect in hyperkalemia events. So really strong testimonial to why we should be thinking about diet. And then if you click forward, here I just put in Predimed, which many say, well, Predimed isn't quite like DASH. There's a lot of overlaps, a lot of similarities, particularly around the fruits and vegetables emphasis. The major difference is that the Mediterranean diet in Predimed emphasized slightly more healthy, unsaturated fats, which was not a component of DASH, but certainly consistent with DASH. And what they found as well is significant reduction in the primary endpoint of acute MI, stroke, or death from the Mediterranean style diet, which was either included the provision of olive oil or increased nut consumption with healthy unsaturated fats. So again, even beyond the blood pressure reduction, we see a lot of benefit from healthy eating in terms of hard outcomes. Next slide. Okay, another recommendation. So what about alcohol? So alcohol is kind of interesting, and we know that from a cardiovascular disease risk perspective, there's a mixed relationship between alcohol consumption and CVD events. And some people say, well, moderate, small amount of red wine can be helpful. And this is distinct from a lot of what is advocated for in the cancer literature, which in some sense says no amount of alcohol is healthy. But when we talk about blood pressure specifically, alcohol reduction does seem to be beneficial. And so the key thing is for both systolic and diastolic blood pressure, the key thing is to come down to a moderate level, right? So for men, that's less than 2 drinks per day. For women, less than 1 drink per day. Some people have sort of questioned the 2 to 1. There is some physiology that has been shown with related to how male livers seem to process alcohol, but by and large, the goal is to get to a moderate goal with respect to blood pressure. And here are some basic standard definitions of drinks, right? Sometimes you ask a patient, well, how much are you drinking per week? And they'll tell you, X number of drinks. Well, is that beer? Is that wine? Is that sort of distilled spirits? I think those are important pieces of information to clarify, though it can be difficult for people to quantify the quantities. Next slide. And what is this based on? Well, there was a couple of meta-analyses that talked about alcohol reduction. In this recent meta-analysis based on 23 studies, they showed an almost linear relationship with alcohol intake and hypertension risk, suggesting that reductions would be beneficial for blood pressure reduction. And interestingly, though, there was a little bit of a difference between men and women. You can see with women, it was more in the higher ranges compared to men. That was more consistent over the entire range of exposure. And then next slide. And then why not stop entirely? So some people have said, well, should I just recommend that people completely abstain from alcohol? And again, there might be reason to do that from a cancer risk management perspective, but from the perspective of blood pressure specifically, this meta-analysis that was quite comprehensive, published in 2017, stratified studies by drinks per day. And you can see at the top, and I know it's a little bit difficult to read, but the first cluster is the 6 and greater number of drinks. Then you have 4 to 5, then 3 to 6, and then less than that. And you can kind of see, if you look at the little diamonds, that's the summary estimate in each of these strata. The biggest effect was in the higher consumption categories, and then that diamond just sort of edges towards the null vertical black line, and such that if you get down to the 2 or fewer category, there's virtually no evidence that this reduced risk of hypertension. And so in many ways, the recommendation is to come down and consume a moderate or lower amount of alcohol, not necessarily to stop entirely. Okay, next slide. Great. Okay, and now in terms of yet another evidence-based recommendation, increasing physical activity. And so the American Heart Association and blood pressure guidelines have consistently recommended physical activity to lower blood pressure. It's amazing all the positive benefits from physical activity. Aerobic exercise should be structured to enhance the maintenance of this behavior long term. You can think about physical activity in terms of its intensity. Moderate, we'll try to achieve 150 to 300 minutes per week. Vigorous, 75 to 150 minutes per week. You can have a combination of moderate or vigorous. This is aerobic exercise. Weight training can also be beneficial, at least 2 non-consecutive days a week. Isometric exercise, this is not as common, but it's important. This idea of like holding a joint in a certain position can be planks, can be various different forms of body positions where the muscle is being exercised, but it's not really it's held in a static state. And then another key piece is minimizing sedentary behaviors or time in the seated position and reminding oneself even throughout your day to get up and move. And next slide. And so here's some evidence just showing the effects. And again, the diamonds are summary estimates for dynamic aerobic, resistance training, and isometric training. The combined was suggestive but not significant, likely because of smaller power, but you can kind of see that all forms of exercise benefit blood pressure reduction. Next slide. And I think at this point, I'm going to turn it over back to Ruth Alma to continue.
Thank you so much, Stephen. I know that we're running a little bit behind, so I'll try to go through this as fast as I can within reason. And so there are several ways that we can support increasing physical activity, both on the individual level as individuals or then institutionally. We can serve as individuals, we can serve as advocates. So what do I mean? Health institutions, for example, can partner with local parks, gyms, community centers, for example, for access. And as clinicians, we can order physical activity prescriptions specifying maybe the activity location, frequency, length, or even specific programs in the community, advocate for or have agreements and partnerships with fitness instructors, fitness groups, support groups, community groups to facilitate the referrals or the engagement in the programs. And these programs can be structured or even personalized. But one thing I want us to also note that even though this is great, it's important to note that it may not be feasible and barriers exist. And we can strive to work collectively to overcome these barriers. And some of those listed here on the slide include neighborhood infrastructure, safety, community support, people's financial positions or employment commitments, and so on. Next slide. Again, some considerations in here. We want to encourage physical activity that is acceptable and enjoyable to people. For example, some people may not like or may not be able to tolerate running, but maybe prefer dancing or a brisk walk. You want to encourage that. And then you want to also come up with creative ways to get those done in the cold, walking in the mall, for example, or in some kind of big public enclosed space. Again, again, accountability, having someone to be accountable to, encourage them to involve their social network, for example, support network, maybe family, friends, be a resource person in your practice setting, for example. You might be able to gather and provide information on local physical activity resources. Maybe it may just be the locational hours of parks, community centers, walking groups, and so on. And encourage people to find creative ways of moving, whether it's standing, taking walking breaks, some kind of lightweight fun competition when people are in social settings to get people moving. Next slide. So now we can move on to other ways to help decrease blood pressure and reduce stress, maybe decrease overstimulation in the short term. And these things include those listed on this slide, things like meditation, mindfulness, yoga, dance, and relaxation techniques, such as deep breathing, maybe your squared breathing, guided imagery, progressive muscle relaxation techniques, which when developed into daily habits, help not only in the short term, but then cumulatively ends up bleeding into the long term. And then what about things that can help ease the load, prevent stress, or prevent people from being overwhelmed? This might be challenging for some of us, including myself. But what about asking for help, maybe delegating tasks and maybe time management techniques, for example, using time blocking, the Pomodoro technique, for example, for focused work. So then techniques such as getting things done or eat that frog. Ultimately, you want to make self-care a habit incorporated into the routine. For example, deep breathing or square breathing while waiting for your coffee or for the elevator to arrive. Next slide. And so here we're looking at healthy sleep. This is also an important part of our cardiovascular health, has been shown to impact blood pressure. And so what are some sleep hygiene techniques that can help us to achieve the recommended 7 to 9 hours contiguous hours of sleep? So first, avoiding long naps, for example. Naps don't contribute to that recommended 7 to 9 hours. And a power nap is ideally about 25 to about 30 minutes long, and that can be refreshing and improve your alertness. But any more than that will leave you groggy and impact your actual sleep time. You also want to have a nighttime routine, just like we do with children. As adults, we actually need those. That includes going to sleep and waking up at the same time each day, including on weekends, turning off or avoiding any electronic devices or screens at least an hour before going to bed, avoiding large meals or exercises before bed, avoiding alcohol about 4 to 6 hours before bedtime, and then having a healthy sleep environment. So it's a cool, dark, quiet room with comfortable sheets. This may be an investment, but little things do matter. I also like to put a plug in here for smoking cessation as a lifestyle change that, when implemented, can lower blood pressure. And next slide. We've probably said a lot, but this slide has a lot of information that I think is important, some of which we've already talked about. And so we believe that for lifestyle modifications that can be adopted in a number of ways. You want to also include those that are tailored, right? So engaging in self-measured blood pressure with logs. And Target BP has a lot of information and resources about self-measured blood pressure. So I won't go into detail with that. There's been other webinars about that. I think in this day and age, we want to also make good use of the technology that's available to us in the form of digital health tools, so they can help with tracking self-measured blood pressure, track sleep, weight, as well as having your food and sleep diaries. We can make good use of reminder alarms that help us stand after a couple of hours of being sedentary, remind us to drink water, get ready for bed, monitor our blood pressure, take our medications, get refills on our prescription medications. And I would like to also say that lifestyle medications are often combined with medications to help manage blood pressure in general, and bring it to target. And we can see some strategies on here to help us and our patients, if your clinicians, maintain or be consistent with taking blood pressure medications. And I won't go into detail, but looking at organizer boxes, reminder alarms to make it easier keeping your medications at the bedside. But then if you take it or you take in a lot of medications and they're not able to fit in a pill box, that's, putting a pill bottle on the side to actually cue you that, hey, you've already taken that medication, for example. So just different ways of that, checking a note on the fridge and a journal, for example. And then when it comes to maybe people who may be rationing their medications, coupons, for example, could help. So obtaining it from manufacturers' coupons, or even looking on GoodRx, for example. And then in terms of cost, large chains like Costco, for example, may have medication discount programs. And as clinicians, we can also look into prescribing longer. So instead of a 30-day supply, do a 90-day supply. And that also helps with cost savings, for example. We'll quickly get into a few case studies. And so, Stephen, go ahead and take over.
All right. So I think we're practically at time, so we'll move very quickly here. But this is a case of obesity and hypertension. So somebody with low moderate risk for cardiovascular disease, but elevated blood pressures that have been confirmed. And so what would be the next best step here? Okay, good. So we have a poll opportunity. And maybe we can reveal the results because we are very limited in our time. Perfect. Okay. And so we had a mix here, and a lot of folks, everything was actually not a bad necessarily answer. And I think people were focusing on either confirming or the lifestyle. We were looking for lifestyle because this person already had the high quality measurement. And I think at some point you want to move on from the confirmation measurement and focus on the intervention side of things. So next slide. And so we have different categories, right, of a recommendation. And so this person's blood pressure would have fit into the stage 1, but low risk category. Okay. And so the first step is lifestyle in terms of interventions. Next slide. And so when we think about risk score, I know there's a new prevent score that's coming out. Some people still prefer the pooled cohort equation, but when you calculate the 10-year risk of cardiovascular disease, then you can use the guidelines. The guidelines are set to be released later this year, so we can see how they determine the cut point. But the idea would be to use risk to inform whether or not to initiate pharmacologic therapy or to focus on lifestyle. In this case, the recommendation would have been to focus on lifestyle, at least based on existing guidelines. Next slide. And I want to highlight that, in the past, we might have thought, well, it's either lifestyle or medications. Nowadays, with the GLP-1 receptor agonists and the GIPs as well, there's great opportunity to actually take a hybrid approach, targeting weight. In our case, the person had obesity. So there's an opportunity to use these medications to treat weight. And there's emerging and very convincing evidence, including this recent paper, that GLP-1 receptors agonists can reduce blood pressure. And I've had patients where I've had to come down on the antihypertensive medications as they lose weight. And so it's important to keep this in mind, especially someone on the fence. This might be a great preventive strategy to improve their blood pressure, even if you're not treating the hypertension directly. Next slide. And some people say, well, I don't want to be dependent on a medication. Can I come off of the GLP-1s? I just pull in this really great paper that shows the role of exercise as an adjunct to liraglutide, in this case, as a way to maintain weight loss, even after stopping the GLP-1 receptor agonist. So again, trying to get out of the kind of yes or no dichotomy of drugs versus lifestyle, and recognizing that nowadays there's ways to treat a body weight, its role in hypertension, and use lifestyle as a way to discontinue that medication too, if that's a patient preference. Next slide. we're just moving quickly. And so I don't believe we have time for the poll here. So I'll just summarize. But this is a person with resistant hypertension already on maximally tolerated 3 doses of medications, including a thiazide diuretic. Workup for secondary causes has been negative. What would we recommend as first steps? And here we focus on both treatment opportunities, mineralocorticoid receptor antagonists. But what we wanted to emphasize in this webinar is that lifestyle still plays an important role. Next slide. And so here we talk a little bit about the definition of resistant hypertension, refractory hypertension. Again, 3 maximally tolerated antihypertensive agents with uncontrolled blood pressure, or controlled on 4 agents, including a mineralocorticoid receptor antagonist. And here is was at least the recommendation for working up resistant hypertension, excluding pseudoresistance with high quality blood pressure measurement, focusing on lifestyle, optimizing lifestyle behaviors, discontinuing interfering medications and substances. Next slide. And here, this is from the DASH sodium trial, which was published in 2021. And what this study showed is that sodium and blood pressure, the DASH diet lowered blood pressure. But what we demonstrated in 2017 secondary paper is that the effect of blood pressure reduction was the greatest among those with the least controlled blood pressure at baseline. And so as high as 20 millimeters of mercury among those with a systolic above 150. Not something we always think about, but you can get even greater blood pressure reductions among individuals from lifestyle, among individuals with poorly controlled blood pressure at baseline. Next slide. And you can click forward, but this just puts this in context, right? So maximal lifestyle benefit was similar to what the effect of starting a new antihypertensive class. And when you look and compare, the Pathway 2 trial was a trial of spironolactone, bisoprolol, and a peripheral alpha blocker for resistant hypertension. And you can see that the lifestyle effect in DASH sodium was comparable to some of the effects observed in this trial, suggesting that it can have strong benefits. And next slide. This old study in 1961 enrolled folks with very, very high blood pressures, gave them, this wouldn't be ethical by today's standards, gave people a thiazide diuretic plus a sodium tablet or a placebo. And if you click forward, what you'll see is that the thiazide diuretic lowered blood pressure, but when it was given with a sodium tablet, there was almost no benefit, suggesting that optimizing lifestyle is even critical for our medications to function. And then next slide. And then here, this is the ENRICH trial, enrolled a population with resistant hypertension, looked at different exercise training programs, and demonstrated significant reductions, 10 millimeters of mercury, reductions in blood pressure from exercise among individuals on maximally tolerated multiple drugs for hypertension management. And then next slide. And this is the TRIUMPH trial. Similarly, 140 people, multimodal behavioral weight management, dietary counseling, exercise intervention in resistant hypertension, and again, significant reductions in blood pressure and improved cognition long term. Okay, next slide. This just shows that if you don't address weight, things can get worse long term. So regardless of your approach, lifestyle matters. And then the last slide, conclusion. So great evidence for lifestyle interventions to lower blood pressure. Interventions can be coupled with drugs in synergistic ways. Those lifestyle interventions are relevant even for adults with resistant hypertension. And we need to work together with medications, with lifestyle, patient partnerships in order to achieve their optimal blood pressure. So I'll turn it over to Allison there. Sorry for keeping you over.
No, thank you both so much. That was such a rich representation of the science and the translation of that into practice. Thank you so much. We're delighted that the slides and the recording will be available for folks to comb through in more detail, because there were so many great tips and great science. I want to spend just a moment and encourage you while I do this, if you have any questions, we've been answering them in the Q&A real time. So if you want to keep asking them, feel free. And if we don't get to them, we can send a follow-up message. I do want to highlight a few resources. One, which is a foundational resources in Target BP, which is our combined quick start guide. And it's like the Matryoshka doll of resources where we have measure accurately, act rapidly, partner with patients, and self-measure blood pressure monitoring sections. And within each of those sections, there are pre-assessment tools for your practice, on-demand continuing education like today's webinar, QI and practice tools, and patient education resources. So I encourage you to explore that and look at your comprehensive approach to hypertension control. On the next slide, I just want to highlight a resource that I discovered, the Healthy Eating Plate that is available through Harvard in 34 languages. So what a wonderful way to have a patient-centered educational material in their primary language. So I think that's a one that was new to me. So I wanted to bring that one to your attention. On the next slide, I really want to debut and tee up a new resource. In our Partner with Patients pillar, which is part of our annual achievement program, one of the first questions is encouraging organizations to adopt a modifiable lifestyle risk factor policy and procedure. In other words, a systematic approach to how you put the things that Ruthama and Stephen were talking about into practice. And so on the next slide, I'll explain what you can find in it. It is now available on our website. It is formatted similarly to the blood pressure measurement policy and procedure template, if you're familiar with that. And it really talks about approaches to systematic practice, defining a standard of care, defining team roles. I know Ruthama mentioned earlier the importance of accountability, and really defining every step in your workflow. How do you make this a standard part of your practice? Leveraging some of the structural prompts, your electronic health record. And then the tool also allows you, as an example here in parentheses, options for you to consider and customize to meet your team, your institution, and your patient population's needs. So on the next slide, I'll just give you a quick flavor of some of the things that are in it to whet your appetite, pun intended. These are the risk factors that it addresses, and it makes you contemplate who on our team are going to be taking on these important roles of collecting data, of assessing patients, of intervening or referring, and what patient population are we focused on. Of note, it doesn't address social determinants. That is a whole separate endeavor and very important to address before sometimes you can get to addressing lifestyle modification if those barriers are standing in their way. And it's one part of a hypertension control strategy. But there are lots of examples of things that might be available within your practice, within your institution, or within your community that we encourage you to inventory, at least on an annual basis, so your whole team knows what might be available to your patients, and sort of steps through, how do we get from the waiting room through a visit and follow-up to address those important needs. On the next slide, I'll just summarize by saying I think it's a great opportunity to bring focus to primary and secondary prevention efforts with lifestyle modification. Think about how to either start define a new approach or refine your existing approach, cultivate your champions and staff skills, and really be a buffer against, turnover happens. But if you write down your processes, it's a great quicker way to get people up to speed. And then ultimately, we hope that it helps you achieve recognition in our annual program. So with that, we're going to move just briefly to the Q&A just to see. I don't see any open-ended questions. What I will ask Stephen and Ruthama, just briefly in a sort of a closing remark each, I would ask Stephen, how do you make time in a busy practice for these conversations?
I think it's always tricky. I do try to identify the patient's goals, particularly during wellness visits. I think prevention is a major reason why many folks are coming to see me. And so we try to just focus on a number of the life's essential 8 risk factors and behavioral factors that are related to cardiovascular disease. And with respect to blood pressure, I think there's often an opportunity to talk about these different lifestyle considerations. And then I try to just kind of engage people to identify, well, of the 6 items we talked about today, well, which ones are relevant for you and which one do you feel like you can tackle? And I think a big emphasis for me is trying to find something that's sustainable for people. Many times people say, well, I read about this or that, but that's never going to work for me. They get discouraged or they try something extreme. They can't maintain it. So I try to find something sustainable, set short-term goals, and then try to schedule more regular check-ins where we can actually talk about progress related to lifestyle goals. And there's a great tool. We didn't have a time to put it up today, but Aisha Langford, who's in Wayne State in Detroit, has this tool where you can actually sit down and set goals with people and put it in the record, sort of like a little table, and then come back and check. And I think that that kind of accountability, I haven't formally adopted it, but I like that approach and concept, is really helpful for people as well in terms of making progress.
That's a great, the bite-sized pieces and collaborative communication are really important themes there. Ruth Alma, let me close with one question for you, which is in engaging patients, creating a sense of urgency around lifestyle modification and its important role. Are there any sort of words or approaches that you use that you have found effective with some patients and engaging them in this important part of their care?
Yeah, a lot of times I think in our discussions, we usually end up finding out or touching on things that are important to them. So for some people, it's being healthy for their family. For some people, it's, having the quality of life now and preventing worsening quality of life. And so we usually just come to find something really salient. And like Stephen said, end up setting goals to work towards those goals. A lot of times people are like, hey, maybe like a relative of mine had high blood pressure, they had a heart attack, they ended up dying young. I don't want that to happen to myself. And I'm like, okay, so what things can we start working on? And then you do some goal setting and then checking in, and you end up developing really meaningful relationships with people that way. And they end up doing really great too.
Thank you so much. I think the relationship development is not something that happens in one 15-minute visit. It's obviously over time. So I appreciate that. I want to thank you both for your expertise and your insights and the time that you spent preparing and sharing this with us today. Again, it is recorded and it will be available to people on the Target BP website. I'm going to move into just a few finishing details, which are to encourage you all to respond to the post-event survey that will pop up when you log off. You'll also get a follow-up email with a prompt for that survey. If you have any unanswered questions or comments or recommendations for future webinars, we appreciate any feedback you have. I actually read every single one of them, so I really value that and count on that after every webinar. If you would like to claim CME or CE credit, you can scan the QR code that was on the previous slide or use that link that will also be in the follow-up email for registered participants. We encourage you to check the website and the upcoming newsletter. If you're not subscribed, please subscribe to that and you'll know when it's available as a recording. You can also visit and see that new tool and resources. On the next slide, I'll just highlight that the data submission deadline for our annual award achievement program is just a few weeks away, May 16th at 11:59 Eastern Time. We have 2 recorded events that we already had earlier this year that you can refer to guide some of your questions you may have. And we have 1 remaining office hours on May 6th, and we invite you to join us for that and register for that event. Lastly, I'll just remind you that we have available self-guided resources through Target BP to improve your quality improvement efforts and to support them. We have the AHA offers a hypertension control accelerator, and the AMA offers MAP hypertension support and for one-on-one support. All of these resources are free of charge, and we have the wonderful ongoing support of AHA's local community impact staff. You're welcome to explore more about these options on our About Us page on the website. And I'll just conclude on the last slide by thanking you again for being with us, encouraging your ongoing efforts and your commitment to improving blood pressure control and take advantage of the resources that are shared with you through Target BP. Thank you again.